Hello, everyone, and welcome to the inaugural episode of Riisfeldt Neurology Education, a not for profit project exploring all areas of clinical neurology. I'm your host, Tom Riisfeldt, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. You can find us at our website at rneurologyeducation.org, that's R for the letter R, for all of our media formats and additional content. You can access our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts. And also please join us on your preferred social media platforms, all located at R Neurology Education, with the exception of X, formerly Twitter, which is at R Neuro Education because of their pesky 15-character limit. Please also email us on contact@rneurologyeducation.org for any questions or queries that you may have. And before we get into it, a legal disclaimer: the content in this episode and in the Riisfeldt Neurology Education project as a whole is for educational purposes only. So let's get into it. This episode is an introduction episode to the podcast as a whole. This will be the only episode in the entire project which is not filled to the brim with actual educational content. So, if you just want to dive straight into content, then please skip this episode now and jump into a content-focused episode that interests you. However, if you'd like to keep listening to a short introduction explaining the project's aims and methods and my own personal background so that you know that you're not listening to a complete numpty, then you're in the right place. So, what's the idea behind the project? So, as stated, it's a not for profit project, meaning that it's open access and freely available. Fundamentally, I believe that for an effective medical education, especially in neurology, there are two core components which are required in a healthy mix. Firstly, you need evidence based medicine, and secondly, along with patient contact, you require anecdotal patient stories and tips and perspectives taught to you by colleagues. You need the anecdotes to help contextualize your learning and make it memorable. Because if you just have the evidence base, then it's dry, boring, it's not memorable, and it's difficult to apply correctly in daily clinical practice. Conversely, if you just have the anecdotes and you don't have the evidence base, then you're not practicing evidence based medicine and your practice may amount to little more than quackery. This project aims to provide evidence based material peppered with a healthy dose of my own interesting, or at least hopefully interesting, anecdotal patient stories and tips, incorporating my own perspectives and the perspectives that I've picked up from many colleagues over the years to help the content stay engaging and be of a high yield. So, who is the target audience for the project? Really, it's anyone who is diagnosing, treating, or otherwise interacting with patients who have neurological conditions. So, that of course includes diligent medical students, neurologists and their trainees, non neurologist physicians, general practitioners or family doctors, and critical care physicians, so emergency and intensive care physicians and anaesthetists, and their trainees. It also includes neurosurgeons, neuropsychiatrists, and their trainees. And I anticipate that nurses and allied health professionals may also derive some value. Although the interested general public are not the primary target audience of the project, they may also derive some value. Now, this is a very broad audience, but I'm confident nonetheless. I very commonly give presentations at work to a broad audience spanning from medical students to subspecialist neurologists, including epileptologists, for example, all sitting together in the same room. The challenge is to make the content both interesting and fruitful and accessible for everyone. And yes, this is a challenge, quite a big one, but it is achievable. Of course, some episodes will be better suited to the more junior audience members, for example, some of the history taking and examination episodes, whereas some episodes will be better suited to the more experienced audience members, for example, some of the deep dive journal club episodes on potentially practice changing randomized controlled trials or systematic review and meta analyses in subspecialty areas within neurology. But I do think you may be surprised. Often, a senior physician can gain value by reviewing and revising the fundamentals, And conversely, more junior audience members can still find the deeper dive topics both interesting and inspiring. The project is aimed to accommodate an international audience. I have an Australian background, so I've done my medical education and my work in my medical career in Australia. And I do believe that my medical and neurology educational background has come from quite a healthy mix of North American and European influences. And there have also been Asian influences geographically. Why do I mention this and why is it important? Well, regarding the Asian influences, is relevant for stroke mechanisms, for example. So we know that intracranial atherosclerotic disease, ICAD, is relatively speaking more common amongst Asian patients rather than in the Western populations in whom atrial fibrillation, AF, may often be the major consideration in those patients. And another example is the significant relevance for anti-seizure medication pharmacodynamics. For example, the HLA-B star 1502 allele and the risk of severe skin reactions, including Stevens-Johnson syndrome and toxic epidermal necrolysis in Han Chinese patients, which limits the use of carbamazepine and, to a lesser extent, oxcarbazepine, lamotrigine, and other aromatic anti-seizure medications without prior allelic testing. I've also personally received teaching from many senior clinicians over the years who did their own training in India, so there may even be some hidden subcontinental influences as well. How am I going to approach this project? Well, I'd like to adopt a semi-casual conversational tone because this is how I personally often learn the best, and I'm sure there are others like me out there who feel the same way. And I do sometimes wonder if I have mild dyslexia. For example, A4 page tables spanning 2 pages printed in single space size 10 font really just doesn't always do it for me. I also want to be time efficient with respect to your time. The content will be uploaded as mixed media formats to accommodate a range of audience members. First, speaking about audio podcasts, I personally work in Sydney, New South Wales, but my fiance and my 3, soon to be 4, children live in regional New South Wales. So for the last 3 to 4 years, I've been driving for between 10 and 15 hours every second weekend. So I've been in desperate need of quality neurology educational audio podcasts over that time frame. And I found there are a handful of really quite good neurology educational podcasts already out there, but the area certainly is not saturated, and I ran out of content pretty quickly. So I felt that there was and still is a need for additional and unique content. I've even tried using talk to text to listen to a chapter of Adams and Victor's Principles of Neurology on one of my drives, and the robotic voice nearly put me to sleep and was nearly the end of me, so I do not recommend that. Additionally, there are a number of high quality neurology journal led podcasts interviewing authors of published articles, but these are highly focused and not very holistic or time efficient. For example, you could spend 60 minutes or more listening to the pros and cons of phosphatau 217 as a serum biomarker for Alzheimer's disease, as opposed to competing biomarkers. But honestly, you could have learnt the same core content in 1 to 2 minutes, and you could have learnt everything that you needed to know about Alzheimer's disease diagnosis in the same length of time. So, the content will be recorded as video presentations and uploaded to YouTube, along with audio-only podcast versions uploaded to all of the major podcast platforms. You really won't miss out on too much by listening to the audio-only versions, apart from seeing my striking face, of course, and the occasional diagram, flowchart, or picture where useful, but I promise to keep big tables to a minimum. The one exception to this will be there will be a few episodes that show me performing some physical examination demonstrations, and of course, these episodes will work better as a video rather than as audio only content. I'll also upload the raw presentations to my website and to slide sharing platforms in both PowerPoint and PDF formats. And I will also upload written transcripts of the episodes to my website for increased accessibility and for anyone who prefers just to read a script, especially if they're looking for some calming reading before bed. You can also email us to subscribe for updates when additional content is released, and I'll also endeavour to release a phone app in the future. Regarding upload frequency, I want to be realistic in regards to this. I do have multiple other professional and family commitments, so I'm planning to record and upload an initial core back catalogue of content reasonably quickly initially, but after that it will be weekly to fortnightly uploads because this will consist or result in a large project spanning many years. And ultimately, I want to and I need to focus on quality, not just quantity, because I don't want to flood the project with rubbish, which isn't helpful for you or for me. So, back to the core idea. I've recently completed my neurology training and I've acquired a lot of knowledge that I would like to record and share before I forget it all in an accessible, efficient, and effective manner. And I've given so many presentations at work over the years, including clinical case-based presentations, didactic topic-based presentations, journal club presentations, and EEG and radiology presentations. But these have only ever been attended by between 5 to 50 people at a time and only listened to once and then forgotten about forever. Instead, I'd like to utilize currently available technology to reach a much, much larger and broader audience in a more time-enduring manner. The project will adopt an evidence-based approach, but it will be supplemented with my anecdotal experiences, tips and tricks, pearls and pitfalls, which I've picked up over the years and which may also aid memorization. And this is the way that I see and the way that I approach clinical neurology. And hopefully, I can communicate the way that I see things to you so that you can do the same if you find it helpful. The project will be primarily focused on making my audience members better clinicians, although there's no doubt that it will also help them pass their barrier examinations. So, the content will be mainly clinically focused, including some clinically relevant basic sciences, namely anatomy, pathology, physiology, and pharmacology, where appropriate. However, this is not the place for you if you're looking for a dedicated platform for basic sciences teaching in isolation. I'm going to focus on presenting information in a clear, systematic way, emphasizing connections between different clinical topics and connections between basic sciences topics, especially pharmacology and physiology. And this is to aid memorization. And I've found this really, really helpful in my own practice. I find that understanding the underlying fundamentals of a topic allows you to memorize the topic as opposed to just learning the facts in isolation, in which case it's like throwing information at a wall and it just doesn't stick and it falls off. So a few examples I'll provide to demonstrate this is, firstly, I remember that antipsychotics can make the extrapyramidal features of Parkinson's disease worse because antipsychotics are primarily dopamine antagonists, and Parkinson's disease is a state of dopamine deficiency which is treated by exogenous dopamine or dopamine agonists or ways to increase endogenous dopamine production. And conversely, pro-dopaminergic Parkinson's disease medications can cause psychosis. And this all makes sense because these medications do the opposite of what the antipsychotics do. Another example is remembering all the challenges involved in treating autonomic instability in Parkinson's disease, given that levodopa can worsen postural hypotension and can then be treated with fludrocortisone. But this can then cause supine hypertension and also fluid accumulation, and can therefore worsen pre-existing heart, renal, or hepatic failure, which can then require diuretics or other antihypertensives, which can then cause a rebound hypotension. And this all therefore requires a very careful balance. And one analogy that a teacher of mine a few years ago taught me, which I've held on to, is that this is like having the tap on and the plug open at the same time. So you have the tap on, the water's pouring out of the tap, but it's draining out of the sink down the drain because the plug's open as well. And many aspects of clinical neurology and clinical medicine as a whole are like this, and it's a good way to understand these competing forces in terms of pharmacology in particular. And one example beyond neurology, just to demonstrate that these principles can be used to understand medicine as a whole, is the way that I remember Conn syndrome. So Conn syndrome is a state of hyperaldosteronism from the adrenal glands, which is a cause of secondary hypertension. And I remember that it's kind of like the opposite state of giving someone an aldosterone antagonist, such as spironolactone. And we know that spironolactone is a potassium-sparing diuretic, which can result in hyperkalemia. So Conn syndrome, which is the opposite, causes hypokalemia. So if you see someone with unexplained hypertension and hypokalemia, then you need to consider Conn syndrome. Otherwise, I would just remember that Conn syndrome does something to your electrolytes, or if I'm lucky, I might remember that it does something to your potassium, but I'd never be able to remember whether it makes the potassium go up or down. From my experience in teaching over the last decade, I know that other people's minds often work in the same way as mine. Turning now to my background. I'm a neurologist qualified from December 2024 and an epileptologist as my primary subspecialty and a neurophysiologist and neuromuscularist as my secondary subspecialty. I'm currently practicing in New South Wales, Australia, finishing off my epilepsy fellowship in Sydney, which will finish in a few months' time. I'm then moving to regional New South Wales early next year to commence as a consultant neurologist and general physician, along with commitments with teaching at the university, hopefully, and a number of research commitments. I've also trained interstate at Canberra in the Australian Capital Territory and internationally at the National Hospital for Neurology and Neurosurgery, Queen Square, London in the United Kingdom, and also at Kilimanjaro Christian Medical Centre in Tanzania. And I've also had a good mix of training in both urban and regional and rural practice locations across New South Wales. As I mentioned at the beginning, I'm also a qualified philosopher and bioethicist, and I've developed some unique perspectives and angles for critical thinking in doing so, which has been really beneficial for enhancing my neurology education and my ability to communicate that education to others. I've also accrued fairly extensive teaching experience in both medicine and neurology at work over the last decade, tailored towards everyone from the medical student level to the consultant neurologist and subspecialist epileptologist and neurophysiologist level. So, I did mention at the beginning that the project is going to be run on a not-for-profit basis. This is because this is my personal passion project to promote neurology education, reaching a wide and international audience. It's non-profit motivated. All core subject matter, which is more than 99% of the content, is open access, easily accessible, and completely free. The content will be organized according to patient presentations, that is, subspecialties, and then by conditions, as opposed to presenting the information by etiologies first up. So, for example, idiopathic Parkinson's disease is discussed with other movement disorders, not with neurodegenerative diseases. And conversely, Alzheimer's disease is discussed with cognitive disorders and dementias, not with other neurodegenerative diseases. Any miscellaneous topics left over at the end will then be discussed based on their etiological basis later on. The reason I'm doing this is because patients present to you with symptoms and syndromes, and they're seen by subspecialists in subspecialty clinics or in general neurology clinics. So that's the way in which the patient is going to present to you. So that's the way that you should structure the information in your mind to remember it the most effectively and to be able to access that information when you need it. There will be additional dedicated neurophysiology teaching, namely electroencephalography EEG teaching, and nerve conduction studies NCS, and electromyography EMG teaching sections. There will be some future premium components to the project. So as I mentioned, it's a not-for-profit project and it's initially being conducted at a financial loss since I'll have little to no revenue stream initially and it will clearly not cover the initial startup costs, and it's being self-funded by my separate clinical work. But I really, really like education and I really value it and see it as being important, and this is why I'm undertaking this project. In the future, once the channel grows, I will aim to introduce a small amount of premium content accessible through a very small premium, probably via access through memberships such as through Patreon or directly on my website, although this will really be to recuperate losses and hopefully break even. If by some miracle the channel is actually successful in the future and does start making an actual profit, then all profits will be donated to effective altruism-backed, cost-effective global health charities as evaluated by bodies such as GiveWell, The Life You Can Save, and Giving What We Can, especially to any of these top charities which may support patients with neurological conditions. I do note that currently none of the top cost-effective charities focus specifically on neurological conditions, but there is considerable overlap here. And for example, there are many ophthalmology-based and micronutrient supplementation-based top charities, but this is the talk of another episode, and this philanthropic effective altruism area is a separate passion of mine. So what will this premium content actually consist of? Well, it will be MCQ multiple choice question banks, flashcards, posters containing flowcharts and diagrams, for example, and other merchandise, along with early access to the content otherwise provided. I may also develop some textbooks in the future if I develop enough content in the coming years through this project. Let's turn now to the organization of the core subject matter. I'm going to be developing a structured syllabus, but I'm going to be very flexible in terms of the upload order. And this is so as to achieve a variety for those audience members who may have differing interests to others. And I'm planning to begin predominantly with the areas of clinical methods, epilepsy, and stroke, and then branch out from there. So, in order, the structured content will be an introduction, classification of neurological diseases, and epidemiology, then some anatomy and physiology, which is clinically relevant, then the clinical method, which will be history, examination, and interpretation of investigation results. And I really do implore you not to skip this series. I know that it's probably not the sexiest area of medicine or of neurology, but honestly, if there's one thing that you can take away from this entire project, the thing which is going to be the most useful overall is having a really, really, really solid approach to history taking and examination, especially the neurologic examination, which can be done well or it can be done not well. Then we'll move on to topics in medical ethics and law, and then we'll move on to the clinical topics with epilepsy and seizures, neuromuscular conditions including motor neuronopathies, radiculopathies and plexopathies, neuropathies, neuromuscular junction disorders, and myopathies. We'll then turn to cerebrovascular diseases and stroke, neuroimmunology and multiple sclerosis, headache and migraine, neurootology and vertigo, cognitive disorders and dementias, movement disorders and Parkinson's disease, cerebellar ataxias, myelopathies, focal cranial nerve palsies, neuroophthalmology, disorders of consciousness and intensive care neurology, sleep disorders, pain and neuropalliative care, and lastly, neuropsychiatry and functional neurological disorder, FND. Then, if there are any disease categories or topics which have not been explored with this approach, we will then adopt an etiology-based approach and address any remaining topics such as other neurological infections, neuro-oncological conditions, other inborn errors of metabolism and mitochondrial disorders, other toxic environmental, physical, and acquired metabolic insults. And then lastly, there will be case presentations and other miscellaneous topics, and then a section on neuroradiology. Finally, a few words on the core neurophysiology subject matter. This will consist of two areas. Firstly, EEG, which will cover fundamentals, and then we'll develop an atlas, a growing atlas of normal and abnormal adult and pediatric EEG. I won't be focusing on intracranial EEG, such as stereo EEG with depth electrodes or EEG with subdural grids and strips, or areas such as back averaging or quantitative EEG, because I don't perform these in my daily clinical practice, but we will touch on some of these areas at a more superficial level. Personally, I found learning EEG really, really, really challenging, and it's essentially taken me 4 whole years to become good at interpreting EEGs. And I did find that the teaching methods and the resources available were really quite limited at times. And I'm therefore really looking forward to the opportunity to try and have a crack at teaching EEG in a more effective and a more efficient manner. So this section will mainly be for neurologists and their trainees, although it will also be relevant for neurointensivists, anaesthetists, and also psychiatrists who are performing electroconvulsive therapy, ECT. Secondly, there will be an NCS EMG syllabus that I'll address in videos and audio podcasts. Again, it will address the fundamentals, and then we'll go on to develop a library of case examples which we'll work through. I won't be going over in depth advanced neurophysiology such as single fiber EMG, visual evoked potentials, somatosensory evoked potentials, or brainstem auditory evoked potentials, because again, I don't perform these in my daily routine clinical practice, but we may address these at a more superficial level. The NCS EMG content will again mainly be for neurologists and their trainees, but it will be also relevant for orthopedic, plastic, and neurosurgeons who need to interpret these results and then determine the best operation to perform on their patients with structural radiculopathies, plexopathies, and peripheral nerve pathologies. So that was it for this episode. Thank you so much for tuning in. Please like, comment, and subscribe. Visit our website at rneurologyeducation.org for all of our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms, all of which can be found at Neurology Education, with the exception of X, which is at rneuroeducation. And email us on contact@rneurologyeducation for any questions or queries. From cortex to curiosity, this has been Riisfeldt Neurology Education. Until next time, keep calm and synapse on.